Welcome to Doctors on Call. I'm Jenna Miller. The skin is the body's largest organ, and maintaining healthy skin requires daily care and protection. However, many people suffer from painful, unsightly, or embarrassing skin conditions, and over 1 million Americans develop skin cancer each year. Skin issues and dermatology, that's our topic today on Doctors on Call with our guest, Dr. Matthew Shaffer.
Presentation of Doctors on Call is made possible in part by an underwriting grant from Gove County Medical Center in Quitter. Healing through caring.
Blue Cross and Blue Shield of Kansas, serving approximately 950,000 Kansans in various programs. A value Kansans trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Neighbors, friends. Dr. Matthew Shaffer grew up in Salina, Kansas. He earned his BA degree in biology and chemistry at the University of Kansas in Lawrence, Kansas in 1993. He earned his medical degree at the University of Kansas School of Medicine in Kansas City in 2000 and completed his internship at the University of Kansas School of Medicine in 2001. Dr. Shaffer completed his dermatology training at the University of Iowa Hospitals and Clinics in Iowa City, Iowa in 2004. Dr. Shaffer is also a clinical assistant professor at the University of Kansas School of Medicine, Salina, Department of Family and Community Medicine, as well as a clinical assistant professor and dermatology lead preceptor, University of Kansas School of Medicine. Dr. Shaffer is on staff with Heartland Dermatology and Skin Cancer Center. Give us a call at 1-800-337-4788 toll-free with your medical questions about skin problems today on Doctors on Call. Doctors on Call brings you information which may be useful to you when you see your own physician. Let's go ahead and get started with some of our questions tonight. Thanks so much for joining us. First of all, what is the most common skin problem that you see in your practice?
So we are a practice that deals with all ranges of skin conditions, from skin cancer to psoriasis, dermatitis, acne, warts, and then evaluation of multiple of other just common skin conditions. We also provide some cosmetic treatments for patients who are interested in looking their best or looking younger.
Sure. Now let's talk about maybe what a red flag might be on a person if they see something on their skin that they need to get in to see somebody.
So in our practice, we see skin cancer every day, and skin cancer, as you may know, is the most common type of cancer, not only in the United States but in the world. There are more skin cancers than all other cancers combined. A red flag for someone would be a spot that is bleeding, not healing, scabbing, on a regular basis, with routine skin care, washing your face, things like that. That should not happen for a normal skin lesion. So if that does happen, that should be the first concern that somebody might need to get in and get an evaluation. Also, anything that's changing, growing. Usually patients are pretty good about knowing something's not right.
So let's talk about prevention, even the obvious. Well, how do we prevent skin cancer?
So most of the sun damage we get before we're 20 years old. And so as a young person, it's up to our parents typically to make sure that we're not doing things that can adversely affect our skin, such as wear sunscreen, wear protective clothing in the midday sun, not get sunburned, avoid tanning beds. Those are the typical things that you can do to help yourself as a young person. But we also see patients as they get older continue to have skin cancers or skin problems or not have skin cancer or skin problems by adjusting their lifestyle to those things.
How treatable is skin cancer?
A very treatable condition. Most of the skin cancers that we see can be treated in 1 or 2 office visits. Particularly basal cell and squamous cell carcinomas, which are the skin cancers that start in the top layer of skin, typically do not spread to other parts of the body, can be treated usually with either what we call a destructive or a surgical procedure. and then monitored going forward. Melanoma is the concerning skin cancer. That's the one that even a very small lesion can spread to other parts of the body. And so treatment and outcome of those is really based on finding the lesion at a very early stage, removing it, and then monitoring that patient going forward.
What should a person look for in their skin, their sunscreen?
Okay, so sunscreen is a hot topic in dermatology right now because there are certain sunscreens that haven't been proven to be dangerous to humans, but also haven't been proven to be safe. There are also a few out there that have now been outlawed in certain places like in Florida and Hawaii, not because they're dangerous to people, but maybe dangerous to the environment, including coral reefs. And so what we generally recommend is a sunscreen at least SPF of 30 that a patient will apply every few hours, and particularly during those to those important areas like the face, ears, neck, top of the hands, and the forearms. The type of sunscreen that is in vogue right now, and it has been for a long time, are called physical blockers, and those would be zinc oxide and titanium oxide. These have small particles in them that don't become absorbed into the skin but actually reflect light away from the skin. And so these are the things like you see the white spots on people's nose and things like that. Tend to be safe not only to the patient, the environment, and also block both UVA and UVB sun rays.
Okay, excellent information. We're going to go to the phone lines now. We've got a caller, Carol, on the line waiting to ask a question. Hi, Carol. Go ahead with your question for Dr. Matthew Shaffer.
Hello. I would like to have the doctor discuss lichen sclerosis, if there's research being done on that, and what he knows about that. Thank you.
Boy, a tough one. So lichen sclerosis can present in a couple different ways. Sometimes we see it in the just in the general skin as what we call an ivory or white colored plaque. Tends to be preceded by a condition called morphea. The lesions are fairly asymptomatic. Patients don't like how they look. We treat them with a topical steroid. It works so-so and tends to run a benign course. The other form, and I think what she's probably getting to, is vaginal lichen sclerosis, which we see occasionally, although the gynecologists see quite a bit. And this can be a condition, again, where there is a white plaque, usually scar-like, in the vaginal area, can have symptoms from itching to pain, can be problematic for a variety of reasons. Regarding research, most rare skin conditions do not get a lot of money for research, and so I'm not aware of this. There may be, but I would be doubtful that there's a lot of money going into this. I would tell this patient to start with their gynecologist, probably already has. Usually it's a topical steroid. Sometimes they get to us eventually. We don't have much more to offer, and it can be a frustrating condition for the patient.
Okay, unfortunate. All right, we're going to go back to the phone lines now. We've got Weldon on the line from Hayes. Hi, thanks for calling Doctors on Call. You're live on the air. We might have missed most our callers.
Ask a question.
Come on back if you got disconnected there. We're sorry about that. So let's talk about acne, and why is acne a little more prevalent in the teen years?
So acne is a multifactorial skin disease that primarily affects younger patients but may extend into adulthood. It is triggered by hormonal stimuli, and so that's why you see it usually in patients around the time of puberty. We see a variety of acne, from a couple pimples to people who have severe life-changing, terrible acne. And fortunately, we're usually able to help these patients. The patients with the milder forms will typically start on a topical, and sometimes as it progresses they may need an oral antibiotic. In severe cases or in resistant cases, we are very fortunate to have a condition called isotretinoin or Accutane. Patients may have heard of it for a variety of reasons. It's frequently a target of lawyers and sometimes in the media. However, in the right hands, it's a life-changing, incredibly effective medication that can take somebody's acne from severe to almost nothing in a period of usually 5 to 6 months. I love the medication. We use it all the time. For adults, sometimes they will also have this, and it can be hormonal, particularly in females. And not only the options we mentioned before, but there's some hormonal medications like spironolactone, which is a male hormone blocker that females can often find to be very effective for their acne.
Okay, we're back to the phone lines now. This is Casey on the line from Winfield. Hi, Casey. Go ahead with your question for Dr. Shaffer tonight.
Hello, Dr. Shaffer. I have a rather large keloidal scar on my chest that I've had a long time. I've had some treatment as far as injections on it, but this was a long time ago. Has there been any advancements made on that as far as reducing the size or anything like that?
That's a scar that overgrows in the actual scar itself. A keloid is an overgrown scar that actually extends outside of the scar tissue. Anybody can get them, but they're often seen in more commonly in patients of color. We treat them typically with injectable steroids, which it sounds like he may have had. Starting off, it's sometimes helpful for symptoms, itching, pain, and slight shrinkage of the keloid or hypertrophic scar. And then sometimes we'll actually remove them again, excise them, and then before they regrow, we may try treatments such as the intralesional, what we call intralesional injections of steroid. And then more recently, there's been some proof that using cryotherapy or actually freezing the keloid either after it's formed or as it's starting to form may help prevent it more than the steroids. So I guess my answer for you is yes. There are some treatments, but you need to see your dermatologist or somebody who has some skill in that and see, based on the size, where it is, which of those treatments might be best for you.
Okay, excellent. Okay, we've got Weldon back on the line. So hi, Weldon. Thanks for calling us back. Go ahead with your question for Dr. Shaffer.
Hi.
Hello, go ahead with your question.
Okay, doctor, I'm a very, very old man.
Well, great.
I have dry skin. Yeah, to my dear age, I have dry skin, thin skin, and it tears quite a bit.
Okay, so common complaint is patients who are a little bit older, who have bruising, thin skin, typically on the arms, is a very common place where they bump into something and they get a bruise that lasts for weeks. And we get questions all the time on how can we do, what can we do about this? And unfortunately, there is not a lot. But I can tell you some of the causes and some things that you might be aware of. So usually for patients like that, they've used a topical steroid or oral steroid in their life at some point, which thins the skin. They may be on a medication that thins their blood, such as aspirin or Coumadin or some of these newer anticoagulants. And so these types of medications not only cause you to bleed, but reduce the structure of the skin, as does sun damage. And so when you get to be a very old patient, sometimes you just don't have much structure in the skin to help prevent those problems. Sunscreen as you're younger, avoiding those medications, sometimes that's not an option, can do it. As far as the dry skin that he talked about, we like lots of products that have a petroleum base, so Vaseline, not to give them any free advertising, but Aquaphor, things like this that have a little thicker consistency tend to be better moisturizers than your lotions and creams.
Okay, wonderful. All right, we've got another caller. Sarah on the line from Wichita is waiting to ask a question. Hey, Sarah, go ahead with your question for Dr. Shaffer.
Yes, I was on Accutane 2 different times when I was in my teens and then early 20s. I'm now about 40, and I've seen some controversial advertisements about how there's the long-term side effects for Accutane users. And I was just wondering if that, if the Accutane would already be out of my system, or if I should still be concerned, or if you have much experience with long-term side effects from the Accutane usage.
It's a very good question. I think depending on who you talk to, they'll give you different answers. But in my experience, there are no significant long-term effects of Accutane. I was fortunate enough to train with one of the developers of Accutane at the University of Iowa, and his comment to me, I remember back in the 2000s, was Accutane's out of your system within about a day. And so we have hundreds of patients on this medication per year, and it's an easy target for a drug to be made, to be made, because it's been it has some side effects that you have to be concerned with. Most importantly are birth defects in a child, but those are typically, well, not typically, always seen in a patient who is currently on Accutane when they become pregnant. And it has to be a female. So a male who would have a child while on Accutane is not at risk of transferring those. As far as long-term side effects, I just don't think it happens. It's blamed for everything. If you watch late night TV, you'll see the lawyers come on and try to get cases for it. But as in my experience, it is a great drug. In the hands of a dermatologist who knows what they're doing, it is a very safe drug.
Okay, excellent. We are back to the phones now with Mike from Russell. Hi, Mike. Go ahead with your question for our dermatologist tonight, Dr. Shaffer.
Yeah, I was wondering if you could discuss the relationship of exposure to Agent Orange and a condition called chloracne and any treatments.
Right. So chloracne is a severe form of acne that is related to exposure to certain types of chemicals. And I don't know if Agent Orange is one of those. We have patients who ask about Agent Orange all the time, and it's hard to give them a definitive answer whether their condition was caused by that. But it is a serious condition. And as far as I know, the only treatments that would be helpful for chloracne, and it would be most helpful when you actually develop it, not 20, 30, 40 years later, would be Accutane.
Okay. And we were talking before some of these calls came in about acne being more prevalent in the teen years. However, we know that acne can be in, Sarah said she's 40. If she still has problems with acne, what does an older person, if you will, what can they do?
So the same rules apply. We would, if it's a mild case of acne, it might just be a topical. There are things called topical retinoids. There's benzoyl peroxide. There's a topical version of a medicine called Dapsone that can be helpful for all of these things. Certain antibiotics might be helpful, and then that medication spironolactone, which is the male hormone blocker, may be helpful. We also have patients who are in their 30s, 40s. I had a lady today who was in her mid-40s that was interested in going on Accutane at this point. The nice thing about as you get older, I find that it takes less Accutane to be effective for a patient than those that are in their teens.
Okay. At the top of the show, you had mentioned psoriasis. Let's talk about what psoriasis is.
So psoriasis is one of the most common dermatologic conditions that walks into a standard dermatologist's office. It is an immune-mediated reaction in the skin. Common psoriasis will affect elbows, knees, scalp, but you can also have a type that comes after a strep infection that can go elsewhere. You can have versions that go to hands and feet, some genital, underarms. So there are a variety of different psoriasis treatments. Over the last 20 years, treatment for psoriasis has completely changed. When I was in training, we had about 4 treatments. We had topicals, which are steroids, which are still probably the mainstay of mild psoriasis. We had light treatment, which can be effective for some patients who have widespread disease where getting a cream would be difficult and they don't want to undergo some of the systemic treatments. And then the systemic treatments would be methotrexate, which is used for a variety of inflammatory diseases in the skin. In the early 2000s, a couple what are now called the biologics came out, and it's really changed psoriasis. Treatments are administered by the patients, usually giving themselves shots on either a weekly or monthly basis. Treatments are significantly better. We see patients who go from 20% body surface area to nothing. They are, in general, safe. The price on them has come down over the years, but still expensive, and has made the quality of life for these patients significantly better.
Okay, what about skin lesions?
So we see a variety of skin lesions that are benign, typically from skin tags, warts, moles, that patients come in and want to know what the available treatments are. Most commonly, it's a simple removal that can be done in the office, whereas some things like warts may take multiple treatments based on how many a patient has and what their locations are. We're always, looking for spots that also may be concerning on patients when they come in for a full skin exam. It is not infrequent when a patient comes in for one thing and we find something else that is the more concerning spot. Probably the most typical spot that a person comes in for is called a seborrheic keratosis, and that's an age spot. These are the brown, crusty areas, typically on the, they can be anywhere on the body, trunk, very common. Sometimes they itch, sometimes they're just unsightly. They tend to run in families, so mom or dad had lesions, and they can sometimes look like melanoma. So for those reasons, patients come in, want them to be evaluated, and we can usually, just by looking at them, tell whether it's something to be concerned about. There are in-between lesions that are hard to tell, so sometimes we'll have to do a biopsy in those cases. Biopsy is a short, quick procedure in the office where we numb the skin up, take a small spot off, and send it to the lab.
Okay. What about diet? How much of a role does diet, good diet or bad diet, play in a person's skin care, regimen?
So I would say in general, diet doesn't play a huge role in the skin. There are a couple conditions. Acne is one that has been shown. The only food actually that has been shown to be contribute to acne was skim milk, which is sort of funny based on people thinking skim milk would be more healthy for them, but the high sugar levels in skim milk make certain patients more prone. There's a condition called dermatitis herpetiformis, which is an itchy rash, usually of the elbows, scalp, sacrum, that is caused by a gluten sensitivity. And so finding that patient out and them avoiding gluten can be very helpful. And then there are conditions associated with diabetes, and typically patients who are overweight that can cause some skin conditions, such as acanthosis nigricans, which is a kind of a velvety darkening behind the neck and under the arms. But in general, things like skin cancer, age spots, psoriasis, Although in the past there was some thought that diet may contribute to psoriasis, but most conditions are not easily identifiable with diet.
Okay, excellent. Wonderful information tonight. Thanks so much for being our guest tonight, Dr. Matthew Shaffer. Next time on Doctors on Call, we'll be discussing arthritis. You can email questions to us for our next program at doctors@shptv.org. Thank you for joining us. For Doctors on Call, I'm Jenna Miller.
Presentation of Doctors on Call is made possible in part by an underwriting grant from Gove County Medical Center in Quitter. Healing through caring.
Blue Cross and Blue Shield of Kansas, serving approximately 950,000 Kansans in various programs. A value Kansans trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Russell Regional Hospital. Experts, neighbors, friends.